If you can hear me, I'm hoping that this is going to be okay. I'm still clicking away.
We can hear you.
Yay! Trying to figure out what I'm doing here. I tell you, if anything can go wrong, Ms. D's going to do it.
Oh, I don't know about that. I think you might have some competition.
Oh! Anyway, thank you everybody for adjusting your time. I was on automatic pilot when I was setting up the Zoom meeting. Class starts at 1, so I thought, well, this is when I do it, and so I made it start at 1. And since that's what I put down in writing, that's when we had to do. So today is our last official lecture on chapters. Next week, what we're going to do is have the final review, the final exam review, and the groups 6 and 7 are going to present that, and it's going to be a lot of fun. So that will be our last lecture, which is April 30th. I think they're planning on something different and fun for all of us to be able to participate with. So having said that, let me see. I'm going to be sending out an email. I heard from Heather that the preference of the class, the majority of the class wanted the DNH 142 final on Monday the 27th, and I'm good with that. And the DNH 146 final on May 4th. So I will be setting those up in the computer. Now I'm also going to be sending out a reminder. Oroscoptic is having a free webinar next Friday, the 30th, which is a very busy day because the MEC is having a virtual health fair at that time too. But in the afternoon, Anne Guillaume is going to be speaking, and she's an international speaker, and she's come to speak with you all as well, but she's going to be talking on ergonomics. So if you're available, I'll be sending you out an email blast about that. But before we get started, let me see. Jessica, the final is not on Monday, it's the review day, right? Oh, I don't know. Monday, the final I have is the 27th, is what I wrote down from Heather. Now I could have written it down wrong. That is this coming Monday, isn't it? Anyway, we'll get into that. Let me see. I have to figure out, and I'm trying to find my emails here. Anyway, I will. I'll be getting back with that. The majority votes picked Monday, April 27th for DNH 142, and Monday, May 4th for 146. So yes, I'm interpreting that the final is going to be on Monday, and the Perio final will be on May 4th. Now, Heen is going to be getting together with the Germana group to review for 142, and I don't know what she set up for 146, but both classes will be getting together for that. I have Tuesday in my head for her final review for that. Does that sound right? Okay. So he is in charge of that. Okay, so let's get on with the principles of periodontal surgery, which is what we started on last week, but this is periodontal regeneration. And there are times when things can regenerate. We've learned from periodontics that once you've lost attachment, that attachment is always lost and doesn't get back. Those fibers don't regenerate necessarily. You can get resolution of pocketing through a long junctional epithelium and shrinkage of tissue, but once the bone's gone, the bone is gone. So let's review what our goals are again for periodontal therapy. We want to arrest the disease process. We want to prevent disease recurrence, as well as provide for regeneration of the periodontium that was lost as a result of disease. So periodontal regenerative surgery is healing after periodontal surgery that actually results in the reconstruction of tissues that were destroyed. And that includes the supporting alveolar bone, the cementum, and the functionally oriented periodontal ligament, which is quite different from what we've learned how your body can respond. So box 26.1, because we're into chapter 26, the procedures used to enhance periodontal regeneration. There's bone and bone substitute grafting to fill in the periodontal defects. There is also prevention or retardation of the junctional epithelium for that downward growth, as well as selective cell repopulation, and that's guided tissue regeneration. There's guided bone regeneration as well. There's acid conditioning of the root surfaces, as well as application of an enamel matrix protein derivatives and growth factor applications to promote specific cell proliferation. So we're going to be going into each one of those. So for surgical procedures, it's pretty standard with any of the procedures. You've got local anesthesia, a flap is made, an incisional flap, and then the flap is raised, and the area is debrided. So the flap of the tissue has granulomatous tissue or diseased tissue, and it's very lumpy. And that part is removed, and then the interproximal crestal bone and radicular bone needs to be evaluated and possibly reshaped. So the objectives of if the interproximal bone is flat, then either an osteoplasty can be done if there are thick ledges that would prevent the primary closure of the flap, and then you can suture the flap, and there's post-op instructions. But if the interproximal bone is not flat, so that's when the probe is walked around, you're doing your 1 millimeter walking, and it dips into a defect, then some osseous resection may need to be done. And periodontal regeneration is indicated. So the need to determine which type of material will be used is then up to the dentist or periodontist. If the interproximal bone is not flat, then the primary closure, which is the facial and lingual proximal flaps, should come together. Postoperative instructions are going to be done. You're closing everything and waiting for it to heal. The primary goal of regenerating lost attachment is the preservation of the natural tooth. The secondary goals are going to include reduction in pocket depths or probing depths, a gain in clinical attachment level, filling of the osseous defects with new bone, as well as new cementum with functionally oriented periodontal ligament fibers going into the cementum and the bone. So to review the type of bony defects, we've had this before. The defects that heal best are the ones that have a lot of bone still around them, right? So a 3-wall bony defect has 1 wall that's missing, and that is the best prognosis, all right, because you've got just 1 wall that needs to be regenerated. You can also have class 2 buccal furcations of the mandibular molars. And those are nice because, again, it's got a little cave, and you can pack in that artificial bone. And then the deeper bony defects are also regenerate best versus shallow defects, because if the deep defect is then restored to become a shallow defect, you're never going to get the pre-diseased state. A lot of times it'll give enough attachment around the tooth. So the best versus the least. Okay, so the best defects, a 3-wall bony defect versus a 1-wall bony defect. You're trying to restore 3 other walls. Class 2 furcation versus a class 3, which is a through and through, and a deep bony defect over a shallow bony defect. And again, this can't be horizontal bone loss because there's nothing to attach anything to. So regenerative surgery differs from osseous respective procedures. Let's take a look at what resection is. Now, the bony walls are removed surgically to eliminate the intraosseous component of the defect, and sometimes the removal of bone will jeopardize the tooth as well as the adjacent tooth. So you don't want to remove too much bone. So if you have a vertical defect, you can't bring the apical area of that bone where that vertical defect is and take off everything so it's level, because then you're jeopardizing the longevity of the tooth. So it might be better to let the bone grow in. So periodontal regeneration involves adding bone or putting a bone filler of some sort into that intraosseous defect instead of removal. So we're trying to regenerate. And again, a 3-wall infrabony defect responds best because you only have 1 wall that's defective. 3 walls around the tooth are still good. And defects with horizontal bone loss can't be treated because there's literally no place to put the material. It's not going to stay in. The bone is flat. That's as good as it's going to get. So there's something called open flap debridement, and that's when a flap is reflected and the roots and the pocket area are debrided without the addition of any bone materials. We talked about that last week, and it's used primarily as a control for comparison and assessing treatment modalities in research. Now, this is when you've got osseous defects. Sometimes you're making a flap, you're debriding, and then you're putting the gum tissue back as part of the periodontal surgery, but you oftentimes don't have deep pockets that you're trying to rectify. These are things that you need to know: the classification of bone grafts and bone replacement materials. This also comes up in your board reviews. Autografts, allografts, alloplasts, and xenografts. So you need to know the difference between each of those. Again, a nice chart that tells you everything you need to know. Autografts are the best because it's bone taken from your part of the body put into another part of the same patient's body. So there's no problem of rejection. An allograft is when bone material is obtained from individuals of the same species but genetically different. So donors oftentimes include human cadavers, and this was a really big issue when HIV and AIDS was just coming out in the 80s. Nobody wanted allografts because of the fear that they would get the disease if their donors ended up having them. But allografts are obtained from bone banks, and the main form of the bone allografts used in clinical practice are demineralized freeze-dried bone, as well as freeze-dried bone, okay? And that is very popular. Then you have alloplasts, which is made of biocompatible inorganic inert material, including synthetic hydroxyapatite, calcium sulfite, bioactive glass, and tricalcium phosphate. So they sound like minerals, don't they? And xenografts, which is a type of natural bone substitute derived from genetically different species. So a xenograft could be bovine or something else. So the classification of bone grafts, the autogenous bone graft is considered to be the gold standard. It's the best for grafting materials in terms of stimulating new bone. Now, one of the name brands is Perio glass, but it's a bioactive glass, and that's a type of alloplast, and that bonds to both hard and soft tissues You have BioOs, which is a type of xenograft, which is from the cow or bovine. That's very popular. You have the demineralized freeze-dried bone, which is an allograft obtained from cadavers. And it's used alone or in combination with something like the BioOs. So the periodontists that are going to be doing this, or the dentists that do these procedures, will have their favorite type of materials that they use, because for them, that's what they have had the best results with. Osteogenic is the process of new bone formation by bone cells from the host or the graft. So an example of that is an autogenous graft, which is an allograft. Think about the intraoral, the chin, the tuberosity, and extraction socket, tori. Where would they take that extra bone? Or extraoral, the iliac crest is used. Sometimes they use, I know for plastic surgery, because I watch Botched, they use part of the rib a lot. Osteoconductive is a term that you need to be aware of, and that is when the mesenchymal stem cells from the graft are induced to differentiate into the osteoblasts, which produce new bone. So examples of that would be allografts, which is the demineralized freeze-dried bone, the bone morphogenic protein, the BMP2, and other growth factors, the platelet-derived growth factors, and we're going to be talking about that. So osteoinductive, okay, is again the mesenchymal stem cells that can differentiate to produce new bone. Then you've got your osteoconductive, and that's bone material that serves as a scaffold or a filler that allows new bone from the surrounding area to grow in and around it. These materials require the presence of existing bone, and the more bone there is, the greater chance of a successful bone fill. So these materials don't produce new bone, but they allow for a better bone fill. Studies really fail to show human histologic evidence of new cementum and PDL, but alloplasts and xenografts are very popular. So the Biologics and Devices, it's the latest addition to the regenerative materials, and it is a growing field. We use biologics and growth factors to enhance wound healing. Growth factors are naturally occurring proteins that regulate cellular events like cell proliferation. So growth factors are found in cells of living tissue, such as your bone and blood platelets. Then you have your GEM21, which is a platelet-derived growth factor, and your bone morphogenic proteins, which are found in bone, and they induce new bone formation. So these are biologics that are being used. Endogain is a pig or porcine enamel matrix protein derivative. It's very popular. Periodontists love Endogain, especially for furcation fills. It's enamel-related proteins from the Hertwig's sheath, epithelial root sheath, and it's a gel-like material. This is a chart that goes over a lot of the different types of bone grafts and bone substitutes. So looking at this, has BioOs is very popular. Perio glass is very popular. In my experience, has anybody else gotten experience from their offices that their employers like to use? So I'm not expecting you to know these names, but know the different grafts, the allograft, xenograft, and that type of thing. The demineralized freeze-dried bone, again, is very popular. And there we've got the emdogain again. So there's a lot of possibilities out there for patients. And the book goes over just some pictures on how the surgery is done. YouTube has a lot of these if you're interested in actually seeing the procedure live, so to speak, in real time. Get on YouTube and see. It's really pretty fascinating, but you can see that this freeze-dried bone here needs to be reconstituted, and you can see how bumpy it is here. So that's the freeze-dried bone being placed, and then you are suturing that in. All right, this is a picture of an autogenous bone. So the patient's own bone was being used to fill in, right? And the body takes over. Reentry at the site 6 months later shows that the bony defect has been filled in with new bone. There's also slight crestal resorption, okay, but the interproximal bone is flat. So we're going for trying to keep the tooth longer, and sometimes we're not going to get perfect results from it. But what are the cells involved in regeneration? There are different types of tissues that's found at the healing wound after the periodontal surgery. Determines whether or not the cells or the healing response will repair. We're looking for that long junctional epithelium. That's repair or regenerate. Now, regenerate is new bone, new cementum, and new PDL. Otherwise, you've got that long junctional epithelium. But epithelial cells migrate the fastest, and they can migrate at a rate of 0.5 to 1 millimeter per day. Now, notice I have that bolded. You need to know that. Epithelial cells move or migrate the fastest. And if those epithelial cells are allowed to migrate into the periodontal wound site, then healing will be from that long junctional epithelium, because that's how it's formed, instead of getting new connective tissue with new bone, new cementum, and new PDL. So when you want to have a long junctional epithelium, that's fine. And that's achieved when the flap is just replaced and sutured against the tooth. But when you're looking for regeneration, you need to have a barrier material in there to stop that epithelial migration. So a barrier will not allow that epithelium or connective tissue from the inside of the flap to fill that defect. It'll allow the other cells to have time to regenerate. So you need a space that's created between the tooth and the flap. That allows the periodontal ligament cells, which are your osteoblasts, your fibroblasts, your cementoblasts, to get in there and to migrate from the periodontal ligament space into the tooth surface, and then the defect can be filled in. So cells from the PDL can facilitate regeneration or bone fill, okay, as well as new PDL fibers. But the only way to know if there's true regeneration is really to take out a block section of the tooth and the bone and to check it histologically. Now, obviously, we're not going to be doing that in private practice. We're using radiographs, and we're using our periodontal probe for our standard detection techniques. But clinicians can determine if there's regeneration, as I said, by radiographic and clinical evaluation. We don't want to probe a newly surgical site for 6 months after regeneration, and that's key. You don't probe it for 6 months. Now, patients that you're alternating with the periodontist, the patients will tell you, I just had this done 4 months ago. Dr. So-and-so said, don't touch it. Trust them. Don't touch it. And hopefully the chart has been flagged and you've seen the referral letter before you bring the patient back. Reentry of the surgical site, which is a minimum of 6 months, is sometimes performed to remove any residual bony defects. Sometimes the bone has little spurs on it and needs to be filed down a little bit. But this is a schematic of guided tissue regeneration. Now, this has been since the 1980s, and it's a very successful surgery. So A, you've got your defect. B, you've got your flap and the defects debrided, and then a barrier membrane's put in place, and that allows, it stays in place for a period of time where the cells can then migrate and grow. You've got healing by regeneration, and the results after therapy hopefully is new bone, new cementum, new PDL. But notice the before in A and the D picture. That bony defect is not at the pre-surgical height, but it's at a very good stabilizing point. Surgical procedure, it's local anesthetic. The patient's always, we want the patient to be comfortable. You have intraclavicular, that's within the sulcus, incisions are made, so they're very deliberate and the flap is reflected. The root surface and bony defect are debrided to remove all of the diseased tissue. And a lot of times they're using ultrasonic as well as hand instruments, sometimes even high-speed hand pieces to smooth out the root surface. It's always nice to know the type of bony defect before going in. Horizontal bone loss, the interproximal bone is flat. You're not going to be able to do anything to regenerate bone there. But vertical bone loss, is it a 1-wall, 2-wall, or 3-wall bony defect? And again, what is the best outcome? What type of bony defect are you expecting the best outcome with? That's my question. Okay, the correct answer would be a 3-wall defect. And being ignored in the chat box. Fine. So the surgical procedure for vertical defects is to deflect the tissue, and it's filled and packed with bone or some sort of bone replacement or a biological bioglass type of material. The flap is then replaced and it's covered, and postoperative instructions are given, and then the post-op is 7 to 14 days later. So this is a picture of a bone plus a membrane is being used for an infrabony defect along the canine. So we've got the canine here, right? And the flaps are reflected, and surgical debridement was performed. And BioOs, which was the biologic, is placed into the defect, and BioGuide is placed on top of the bone graft. That is to prevent those epithelial cells from migrating, and then the flap is sutured. Now, this used to require a second surgery to remove that barrier membrane, but they now have resorbable barrier membranes, so oftentimes a second surgery is not necessary. Another picture of the mandibular right quadrant. All right, you've got your A before and your B, then your C is the full thickness flap. D is after debridement, and then there's demineralized freeze-dried bone placed. Then there's an absorbable membrane that's sutured over the defect. Now again, that membrane is preventing those epithelial cells from taking over. The flap is sutured. 1 week post-operative, the sutures are removed. 4 weeks post-operative, the membrane is still in place. It will slowly absorb. And when can you probe that baby? Do you remember? How long do you have to wait? 6 is correct, but it's 6 months, not weeks. Yeah, there you go. 6 months, not weeks. So absorbable membranes, all right? You've got synthetic material, you've got bovine material, which is natural. Gore-Tex was the first membrane that we used for years and years, and that did not absorb or resorb, so that required a second surgery. So you don't need to know the names of these, but know that there are synthetic and natural ones, and the natural ones are usually bovine. Non-absorbable membranes were first used. Again, it did require a second surgery. Gore-Tex was the, Tef-Gen also was used. I don't have any firsthand experience with that. But that Tef-Gen evidently can remain in place for 9 months. Again, I have no knowledge of that. I've never seen that one. Absorbable membranes are preferred because they absorb and you don't need a second surgery, but the barriers need to be in place for a minimum of 3 to 4 weeks to allow regeneration to start. Otherwise, those epithelial cells from the connective tissue is just going to take over. Surgical procedure, you have your local anesthesia, your intrasulcular incision, flaps, periodontal debridement is done. Then inspection, you are determining what type of defects and what type of furcations are going to be needed. Then the bone material is placed first before the membrane, and then you put the membrane on because the bone is placed first before the membrane to prevent collapse of the membrane into the defect, right? So you've got to have that scaffolding there first. And then the membrane must be covered with the flap to avoid contamination with the oral environment. And instead of sutures, sometimes stainless steel tacks can be used. I haven't seen stainless steel tacks in years being used to hold the membrane in place. Tacks can be removed weeks later. You as a hygienist are going to be involved in teaching the postoperative care. Avoid brushing the surgical site. A lot of times they're swabbing and rinsing with chlorhexidine rinse. After suture removal, they have ultra soft toothbrushes that can be introduced and continue with the mouth rinse. So these will give you some ideas of what the post-op is all about. Patients are usually coming in more frequently during the first couple of weeks. Sutures are removed, then they're coming in and they start expanding the length of time in between appointments. But you might be involved in suture removal, and you're going to learn about that in dental materials in DNH 214. It's really easy. The hard part for me is always trying to manipulate those big scissors that they have in their suture kit. They're just too big. I want tiny little cuticle scissors, but they've got these big old things with big handles on them. But anyway, so you remove the sutures. The periodontal probing, again, should not be done prior to 6 months after surgery, right? And that's what I want you to really have the takeaway here. Final prosthetic restorations, again, aren't completed until 6 months or more after surgery because they have to know where that gum tissue, where that margin is and bone level is going to end up. Guided tissue regeneration, GTR, right, is still being done, very popular. Between 4 and 6 weeks, though, that membrane is removed. So if they need to have a non-absorbable membrane, they have to come back. The flap is deflected again, and you remove that. But with absorbable membranes, you don't need to worry about it because it resorbs, and you instruct the patient to resume normal toothbrushing and interdental cleaning at 6 weeks, right? For non-absorbable membranes, at 8 to 12 weeks, they have to go in for that second surgery. Right, are there any questions pertaining to surgical regeneration? No. So look over the terms. You've had a lot of this already, so hopefully it is it's a review for you. And I got to figure out what I'm doing. '26. Okay, let's take about a 5-minute break, and when we come back, we'll go over our next chapter. So we'll come back at 1:36.